Hi, everyone. Welcome to the PrecisCa GU Tumor Board. My name is Brian Reaney. I'm a GU medical oncologist at Vanderbilt, and I'm happy to be joined today by a prestigious panel of experts from around the country to discuss several cases. I'm going to go around and have everyone introduce themselves before we get started with our first case, and I will start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm a genitourinary radiologist in the abdominal imaging section at Washington University in St. Louis.
Thank you. Dr. Shaw?
I'm Chirag Shah. I'm a radiation oncologist at the Taussig Cancer Institute at the Cleveland Clinic.
Thank you. Dr. Abel?
Yes, thank you for having me. My name is Jason Abel. I'm a urologic oncologist, a surgeon at the University of Wisconsin.
And thank you. And Dr. Jakaki?
Hi, everybody. I'm Alexandra Drakaki. I'm a GU medical oncologist at UCLA. Happy to join you today.
Thank you all for being here. So we have several cases across the spectrum of GU cancer to discuss today. And we'll start off, and I'll sort of describe the case and the question, and then we'll go through some specifics of the case. And then I'll come back to all of you for an opinion, depending on what the specifics of the case are. 48-year-old man, history of pathologic T3 grade 4 clear cell RCC, got a radical nephrectomy and actually got a year of adjuvant sunitinib, as we talked about with a different patient. And now, unfortunately, has a solitary brain met a year and a half after completion of adjuvant therapy, resection which confirmed disease and undergoes restaging scans and has retroperitoneal lymphadenopathy as well as a recurrence in the renal fossa. And so the question is about recommendation for treatment. So this is a patient who presented with new onset seizures, performance status of 1, medical history significant for hypertension, hyperlipidemia, no alcohol or drug use or tobacco use, married with 3 kids, works as an attorney, had a brother with prostate cancer at a young age, and was diagnosed with T3 grade 4 clear cell RCC, got radical nephrectomy, and then completed a year of adjuvant sunitinib without incident. 18 months after the end of that, so I guess that'd be 2.5 years after surgery, unfortunately presented with seizures, had imaging that showed a solitary brain lesion, underwent surgical resection and pathology confirmed RCC, and now he has these staging scans. Let me pause and ask Dr. Shaw. You know, we do a whole lot of SBRT to brain lesions. I did when I was in Cleveland. We do now. When do you, if you had seen this patient before surgical resection, they have, had a high risk RCC. They present with a brain lesion that looks like a MET. Do you think surgery is mandatory for pathologic confirmation in this patient, or no?
It's a good question. So, if the patient's not having a lot of symptoms, I think, we tend to not always do surgery in these situations. But in symptomatic patients, we always do discuss with neurosurgery the role of resection, given it sounds like he's presenting with seizures. I think that would certainly be a consideration for upfront surgery followed by adjuvant, either radiosurgery or gamma knife to be done post-operatively would be how we would typically manage it given his seizures. You'd also be able to get tissue diagnosis to confirm metastatic disease, but that in itself isn't a reason for us to commonly perform, brain tumor resection.
Yeah, and I think that's the question. It's really about probably anatomy and symptoms and complications as opposed to pathologic confirmation of what you probably know as a metastatic site.
Correct, yep.
Yeah, and Dr. Jakaki, how about at UCLA? Anything different in terms of the approach to RCC brain mets?
So recently we have the laser ablation. So again, it's minimally invasive procedure, but they have to go through, small craniotomy where they're able to do biopsy and laser ablation at the same time. So I just had a patient that underwent that procedure a couple of weeks ago with good outcomes, short course of steroids post-procedure and no neurologic compromise, but again, depends on where exactly the lesion is.
And I'm sorry, just for me and everyone, can you describe that more? What is it? It's an invasive procedure, so they're going in through with craniotomy,
and they're able to put their probe, they're able to get tissue, and then with their probe, they're performing laser ablation. So it's not radiation, it's not resection, but it's ablation, and it's performed by the neurosurgeons.
Okay, it's local therapy, but you get the advantage of getting tissue. Okay. And now this patient has restaging scans that show retroperitoneal lymph nodes and a recurrence at the nephrectomy bed. Dr. Siegel, if you could help us through what you see on these images.
So we have here 3 images, 2 axial and 1 coronal, from a portal venous phase CT. And portovenous phase CT is best to look for liver metastases and our standard sort of imaging for the bowel and the abdomen and pelvis. I had mentioned earlier that we do pre and post with nephrographic phase imaging when looking for a renal mass. So we can see here that there is extensive peri-aortic adenopathy in the nephrectomy bed, extending all the way down to the common iliac level. And on the coronal view, you can see this sort of elongated lobular mass extending along the left margin of the aorta.
So, Dr. Abel, do you want to go in and cut all this out?
You know, I think something like this, it's tough because it's definitely technically doable. But really the question is, you know, how's that going to benefit? And I think the biggest limitation is for any of the metastasis-directed therapies is that there's probably other microscopic disease that we're not treating. And in discussing like that with the patient, this doesn't seem like your optimal patient for that. Really, patients that have a slower natural history of disease, that have just one or two spots, this is pretty extensive in many places. And I just don't think we'd be doing them a benefit by going in and removing everything we see.
And so let's take the brain mets out of the equation, because obviously that's sort of, you know, that's a bad actor, and we all sort of have pause with doing more aggressive things in those patients, at least surgically. So take that out of the equation. Is there a volume of disease that you think is a threshold for resecting versus not? Because you mentioned, gee, there's a lot of disease there. So and I know this is an unanswerable question, but I'm going to ask you anyway. Is there a volume of disease that you sort of think in your mind, either quantitatively or subjectively? And then the second part of that question is about time since nephrectomy. You know, obviously the longer the better, but do you have in your brain those? Is it quantitative at all, or is it more just subjective on both those fronts?
I think it is pretty subjective. I think anything less than a year since the index nephrectomy is really a bad idea. I think after a year, you get people more willing to operate, especially on a solitary site like a solitary adrenal or something like that. Now, this is pretty diffuse, meaning extending all the way from the abdomen down to the pelvis. And I just think from a bulk standpoint, you're not going to remove enough to really justify the extent of the surgery that you're going to have to do. Again, I think if you can do it technically, I just don't know what benefit it is to the patient, and I don't probably think it's in their best interest.
Yeah, agreed. And this is something, you know, of course we struggle with in clinic. We want to be aggressive, but we don't want to be too aggressive, and it's a fine line. That's why I asked those questions. So really, it's about where to go now. Dr. Drakaki, I'll let you take this one. So nephrectomy, a year of adjuvant sunitinib that ended about, I guess, 18 to 24 months ago. Brain met resected and has fairly extensive abdominal disease. Let's assume there's no other contraindications to therapy. What are you choosing for this patient? So
I think at this point, I would consider a dual immunotherapy. We have evidence about the use and efficacy and safety of nivo-ipi in patients with brain metastases. So I'm sure he may have recurrence in the brain in the future. He may still have some micrometastatic disease in the brain. So I think the nivo-ipi will be a good way to control him systemically at the same time to protect his brain a little bit. He already got the VEGF inhibitor. We know that ipilimumab can increase the toxicity, so doing a nivo-cabo would be an option also, or any IO VEGF. The question is, what procedure did he have in the brain? Because if it's really post-operatively, if he underwent surgery, the risk of bleeding with the VEGF inhibitor is high. So I would like to buy some time between any surgical intervention and VEGF inhibition. So again, probably we'll start with the nivo-ipi approach and keep the combinations later on.
So it sounds like nivo-ipi, and I heard three reasons. Maybe one, because he already got a VEGF inhibitor, he already got sunitinib. One, because he had brain mets, and there's some data, I think more in melanoma, but there's some data about efficacy in brain mets.
We're publishing the BMS 920 trial, cohort 3, where patients with brain mets only had benefits. So this is coming up in upcoming meetings this year. So giving you some hint ahead of time.
At an upcoming Congress near you. And then the third reason was just surgical, just from a wound healing standpoint. Is one of those driving it more than the other, or is it sort of just a collection of all three?
I think the nivo-EP and benefit CNS disease is the driver. Again, just because I had treated a few patients from that one trial, I have patients for years since diagnosis with no disease progression from nivo-EP. And again, it's always the challenge of controlling the side effects from immunotherapy. But I think this is the main driver.
Yeah. And I think that's totally reasonable. I mean, I think, not many people are getting adjuvant sunitinib, right, as we talked about. So that's not really driving too much. But if pembro and other agents are very common in the adjuvant setting, which I suspect they'll be given like water, then I think it really will shape frontline therapy. And I wonder if somebody just finished a year of adjuvant pembrolizumab 6 months ago, 12 months ago, 18 months ago, are you going to then give them nivo cabo? Are you going to give them nivo ipi? I don't know what the answer is. I don't know, but we're going to have to rethink sort of the whole approach to frontline, depending on the timing of recurrence, I imagine, as much as anything.
Inhibitor first line, that may be the next option.
Say that again, I'm sorry.
And if we have a HIF inhibitor in the first line setting, there's some trials that are running right now.
Correct.
May that be a good approach.
Correct. Yeah, I think it'll be a while before those are approved, but I agree with you as well. So just to summarize, a man with resected kidney cancer, adjuvant sunitinib, resected CNS met now with sort of bulky retroperitoneal disease. And the recommendation I was leaning towards IO, that is ipi-nivo, based on what we talked about, surgical healing, prior VEGF exposure, and brain mets. Although I think IO TKI would be reasonable as well. That's usually how we end these debates, that both are reasonable, but I think IO is reasonable.